Good afternoon. Welcome to the colloquium promoted by Shared Patient Experience Association. My name is Joan Escarravill. My clinical background is a chest physician, but at this moment I work in the chronic care program and the patient experience evaluation at Hospital Clinic in Barcelona. It will be a pleasure to chair this meeting and to share with you a lot of ideas. The panel is a very expert panel. I will introduce the experts after my presentation, but here we have Jessica Denning from the European Lung Foundation. We have Professor Antoni PLASENCIA from Global, and here in my left side we have Professor Toni CASTELLS from Hospital Clinic. The idea of this, I will share with you a short presentation in order to introduce the colloquium. Sí, ara haig de fer el share, no? Zoom. Aquí.
Compartir.
Em vaig aquí, no?
Sí, senyor. Obrim això aquí. Compartir pantalla.
Okay, I think that works. This seminar, it's under the umbrella of Patient Experience Global Response to Society in search of high touch. Shared Patient Experience Association organizes 6 seminars. This is the second seminar, and the main topic of the seminar is how to develop the patient experience in the context of isolation. This is a perspective very closely related to the COVID experience, and the agenda of this seminar is like this. We started with a short introduction about the clinic hospital and the relationship with clinic hospital and shared patient experience. Then at 4:15 p.m. More or less, all the speakers will summarize the presentation. Remember that you have the full presentations in the video that is accessible in the web page. I will share the address in these presentations. We will have 30 minutes approximately of a discussion between the panelists, and then we will open the discussion to the audience. We strongly encourage you, the audience, to submit questions via chat. We will summarize the questions and we will share the questions with the speakers. As I said before, I work here in the Hospital Clinic. Hospital Clinic is a high complexity hospital from the city of Barcelona with more than 700 beds, more than 4,000 professionals, and the activity is high activity for more than 44,000 discharges each year. But the dimensions of the hospital, in order to understand the hospital, we need to consider 3 dimensions. So one dimension is the reference hospital, it's a high-tech hospital, but also we have a dimension of a community hospital for the 500,000 inhabitants in the city of Barcelona, and we have a very important dimension related to the academic activities. In order to summarize the scientific activity, I can share with you that we produce 1 index paper every 7 hours. No? That means high scientific production with strong links with institutes of research like EDVABS or Global, that Dr. PLASENCIA is the director, but other organizations that promote research in the hospital. And the question is, why does a university hospital very focused in high technology and in research decide to take care of the people, decide to focus also in patients? And this is the only explanation for that. It's a very crucial event in the strategic plan of the hospital in 2016 to 2020 that talks about the interest of the hospital for people. But the interest for the hospital, not only for patients, because of course the main focus of the hospitals, every hospital is patients, but also the focus for patients and professionals. And this is a good image. It's a cover of the British Medical Journal 20 years ago. that show the good relationship between health professionals and patients and the partnership. The good example is the tango. I am a very bad dancer, but people said that tango is very difficult to dance. And this is the idea of the strategic plan of the hospital. People is a good relationship, a good partnership between patients and health professionals. For that reason, we promote a lot of activities in relationship with patients and promoted by patients. For example, the volunteers. We have a web page with more than 1 million visits. It's a web page focused on the patient's needs. Also, we work in order to promote the human touch in the intensive care unit or the support for patients for a specific disease. But the key issue in 2019 was the living lab. This is a space of the hospital focused on the evaluation of the patient experience. It's like a test bed. It's the so-called an open space and a space that we can talk about a lot of issues with the patients, not only for the patients, but the more important issue is that this is an open space to work with the patients. The main objective is to identify unmet needs of the patients, and we use different methodologies, ethnographic design, focus group, surveys, interviews with patients. It doesn't matter the methodology. The main objective is to improve care, to improve the experience of the patients through the identification of unmet needs. And this is very close related to the objective of shared patient experience. We can summarize 4 main ideas that are shared by the hospital clinic as a member of shared patient experience. The first one is we want to collect ideas and experiences of the organization in order to improve a patient's experience. At this moment, everybody agrees that the patient experience is the third pillar of the quality. The first one is safety, the second one is effectiveness, but the third pillar is, of course, the patient experience. We want to promote a patient-centered model, but this is probably a motto that use it sometimes, but I love to say that it's patient-centered model in the real world, not as a theoretical framework. That means that in practice, it's very close related to the patient's needs. We want to share knowledge and we want to disseminate research related to the patient experience. With these objectives, these general objectives, we focus the main topic of this seminar around the isolation. When we organized the 6 seminars, we said we need to talk about the patient experience and related to the COVID. No? At this moment, it seems that it's impossible to talk about some aspects of medicine, clinical practice, without the umbrella of the shadow of the COVID problems related to this. But why isolation? Why the word isolation? What do we want to share with you talking about the isolation? Because we are used to deal with different pandemics, but in this case, probably there are some differences. The first one is the COVID affects all the world, all the countries in the world. Practically affects all the people because it's very difficult to identify just a risk group and a specific risk group that it's a priority, but all people, but in general affects. But in my opinion, isolation is a new idea. I remember in the 70s when I started my studies in medicine, I had some friends that need to go to the tuberculosis sanitarium. It was an isolation, it's clear an isolation, but for a small group of people, for a long period of time, more or less long period of time. But this is not a social isolation. Also, I remember in my residence, as a resident in the hospital, the isolation in the infectious unit or in the intensive care unit. This is just a small number of people. But at this moment, we face with isolation in all the aspects of the life. Isolation in the hospital, even in the end of life. In the end of life period, patients were alone in the hospital, and this is a tragedy. It's very difficult to deal with, but also isolation at home or isolation in the family. The grandfathers can meet the grandsons. That this is it's stressful, and this is different from other pandemics. And for that reason, we said that isolation makes sense to talk with this. And the isolation for all people with a great impact for most of people, but also it's to understand the pandemics, we need to identify the global impact. But this is not just a local impact, but the solutions are locals. And this is, in some aspects, some people could say that this is a contradiction, but this is a reality. The global solutions don't exist because the one-size-fits-all don't work in this case. The second idea, the first one is isolation. The second idea is information. In February, the Tedros Adhanom Ghebreyesus, the director of the World Health Organization, said that this is a very important problem. The COVID is a very important problem. In China, there is a very important problem. And we need to work in facts, not fear, in rationality, not rumors, in the solidarity, not in stigma. But 1 month later, in the Guardian, the journalist, John Naughton in the Guardian, said 1 month ago we said that China 66,000 cases, the rest of the world just 500, and the surprise of Tedros was that the lack of urgency of the international community, the severe disruption in the market for the personal protective equipment, the level of rumors and misinformation, and the impact in the countries with weaker health systems. This is a real problem that we need to talk and to introduce these ideas and to try to identify the patient experience in this context. We want to talk from a local perspective in a hospital. We want to talk from a global perspective. What's the perspective of the international organizations, and what's the perspective of the patients? To do that, we have here 3 speakers to explain this problem. The first speaker is Dr. Antoni CASTELLS. You can read the curriculum vitae in depth and more extended in the web page. I just want to share with you my knowledge of Dr. CASTELLS, and he's a tireless worker. It's a good researcher. He promotes the colon cancer detection program in the hospital. But Dr. CASTELLS has 2 very important characteristics. One is he has a great sense of humor. This is very important. And the second one, working with Dr. CASTELLS is very useful for us because we can learn a lot of things. Moltes gràcies, Toni CASTELLS, per ser aquí. The second speaker is Mrs. Jessica Denning. Jessica Denning is a communication and education coordinator of the European Lung Function. For me, as a chest physician, it's a great pleasure to share the perspective of the patient with chronic respiratory disease. In fact, all my professional life, I worked with chronic respiratory patients. And the European Lung Foundation promotes the perspective of the patients in the last 20 years, was founded in 2000, I remember. And Jessica Denning will help us to take into account the patients as an active partner. Thank you very much, Jessica, for your participation. And at the end, from the global vision, Dr. PLASENCIA is the Director General of eXglobal. eXglobal is an institution working to improve the health through excellence in research and to knowledge translation. Dr. PLASENCIA has been working in the epidemiology, in the public health in the last 30 years. And I remember perfectly 10 years ago, in the course of the avian flu pandemics, I was a direct witness of the work of Dr. PLASENCIA as a director of the public health. And at that time, I was impressed with the combination of the pragmatism and knowledge that Dr. PLASENCIA showed. Were difficult times. Moltes gràcies, Toni, per la participació. Molts t'enyorem. This is just a summary of the presentations, and I suggest to spend 10 minutes each speakers in order to summarize the 3 topics. I remember the audience that you can follow all the videos in the web page of the shared patient experience, and then at the end of this seminar, we will share with the audience we record all the seminar, and will be open to you. And no more introduction. I will finish this. Dr. CASTELLS.
Okay, just 1 second. Okay, thank you very much, Joan, for your nice introduction. I want to correct you because I am the person that I learn from you. You teach me every day about the patient experience, and I learn a lot, and I enjoy the conversation that we have many times, talking about many topics, not only related to the health system, but also about politics and other things. Okay, second, thank you very much for the organization for inviting me to participate in this webinar. Unfortunately, I have an unexpected event. I mean that I'm going to make this short introduction or short summary of my presentation, and then I have to leave out because I have an unexpected event that preclude to continue being with you. Well, the COVID was a terrible and terrific experience for all people that were running in the hospital or running or were in the direction of the hospital during the beginning of this pandemic. I mean, I still remember here in Barcelona, the peak of the pandemic was about end of March, beginning of April. And at that moment was a real nightmare. I mean that every day when I went home, I suppose that the day after the hospital is going to collapse. Actually, probably it's going to be the experience, the most terrifying experience in my professional life, because I've never faced a problem like that ever before. For me, for me and colleagues that we shared during this period of time, COVID was a problem because of 3 different circumstances. The first is about the magnitude. I don't know, probably we can share with different hospitals that in each country is a little bit different, but in Spain and in Catalonia, and especially in our hospital, was very difficult to manage the pandemic. Just to give an idea, our center is an academic university center, tertiary center. We have 700 beds. And at that moment, or when at the end of the first part of the period, I mean during the first half of the year, we have attended more than 2,500 COVID patients, besides the non-COVID patients. That means that the magnitude was quite huge. The second is about the rate. At the beginning, I remember at the end of March, beginning of April, that we are admitting to the hospital around 100 patients every day. And that was very difficult to manage because our hospital is a little bit old, it's more than 100 years old, and we cannot accommodate our facilities to admit so many patients. And the third fact that I think that many of you will share with me is that, or will agree with me, is about the uncertainty. At that moment, we didn't know many things about the disease. We didn't know about how to treat this disease, how to prevent, how to manage in general. I mean, that was very difficult, no? And at that moment, we're really concerned, we're worried about the impact of this pandemic in patients, in the health, and also in the psychological status of our patient. As Dr. Scarabelli mentioned before, one of the factors was isolation, because we have never experienced an isolation like that before. It's he mentioned is a social isolation more than an isolation specifically to control the disease, and that make very difficult to manage this situation, not only for the patient but also for his or her family. We make many questionnaires. Indeed, Joan was leading the patient experience department in our hospital, and he addressed many questionnaires to both health workers and patients. And this questionnaire reflect probably when we talk with a professional that one of the fact that terrified the most, or that they are really concerned, is to take care of isolated patients. They considered that was the hardest part of his job, and actually that it was a problem. We are asked to patients about how was the experience in our hospital, and most of them were very comfortable. I mean that they agreed or they considered that they receive a very good support and medication. There were some patients that are critical about about food, about the housekeeping. That is quite normal in many questionnaires, not only related with COVID, with other circumstances. The patient reflect that this aspect, there is room for improvement, but they consider that we are doing pretty well. About our concern about isolation, we try to manage in different ways. One is a program that we started in our hospital that we name shortening distances. That was ruled out by the psychological team of our hospital, actually the section of health psychology. And this program tried to address the needs of patients that admitted in the hospital, that they are isolated, that are far away from his or her family. And sometimes is just providing some devices, for example, a cellular phone or a phone charger, in order to facilitate communication. But in some cases, you can imagine that there are patients that they cannot hold the mobile, and these professionals help these patients to establish or to set a phone call with his family. Sometimes the patients need more than psychological support. Sometimes it was the family that needs psychological support, and sometimes also the health workers need psychological support to continue working in the scenario that we're facing at that moment. And finally, probably is one of the topics that Joan Scarabillo, one that I address in my presentation, is to consider how to manage other clinical conditions besides COVID that we are usually attending in our hospital. And during the pandemic, we make an extraordinary effort to continue attending this patient, the non-COVID patient. And sometimes we were worried about, or we are concerned to consider these diseases as invisible diseases, because they are not in the focus. They are not talking about that in the press every day. And we try to do an additional effort to attend this patient, because we consider that is a measure of equity to attend both patients with the COVID and patients without this disease. And we did many evaluation. Again, Joan was the person responsible for this evaluation. We make some focus groups with patients and also with some professionals. You use video conference because at that moment we consider that was the safest way to try or to do this focus group. And we want to address some specific diseases, where we make a focus group about chronic headache, also about patients with that are receiving a kidney transplant or are submitted to dialysis, and also patients with obesity. I think that the information that we achieved with this focus group were very interesting. We address, or Joan addressed specifically one question, that what is the quality and the quantity of information that they are receiving all the time. And they consider that they are pretty informed, but they consider that we should make an additional effort to transmit, to communicate practical information. Sometimes they consider that there are too much information. I think that they use the word infoxication, because we sometimes receive too many news every day from newspapers, TV, radio, and this infoxication is an overloading information that sometimes is not helping our patients. Just to finalize my summary, I just want to point out one aspect that it surprised me the most. Probably Joan is much more familiar with this aspect, but I was surprised because when we talk with patients about the shortening distance program, they consider that is an excellent initiative. It was an excellent idea that they really enjoyed, but there were some patients that they consider that they didn't want to communicate with his or her family, and even there are some cases that consider that communication could have some adverse events. I mean that there are these two ideas. I don't know, maybe during the debate or the discussion, we can try to address this discordance between the positive and negative aspect of the communication program. Thank you very much.
Thank you very much. Thank you very much, Dr. Castells, for your nice summary. The second aspect that we want to explain here is the summary of the presentation of the Jessica Deming. It's very important because at this moment, Jessica Deming represents the perspective of the patient. It's the most important mistake that the doctors do is to make suppositions. We suppose that the patient wants, we suppose that the solution is very easy. Ask patients about the problems or the main needs of the preference. And the floor is yours, Jessica. You can summarize your presentation in 10 minutes. Sarah Uri.
Thank you. Okay, great, excellent. Thank you for having me today. Would you like me to just very briefly summarize, or do you want to see some of the slides as well? I could share my screen if you'd like, or not.
Whatever is easier for you. If you want to have the support, that's perfect. Otherwise, just the rest.
It's okay. I'll just I'll talk. I've got them open so I can kind of just see. So yeah, I'll give you a very brief summary. For those of you who aren't aware, the European Lung Foundation, as was previously mentioned, was founded in 2000. So we've been around for about 20 years. And we were founded by the European Respiratory Society. And it was with the aim of bringing together patients and the public with respiratory professionals to positively influence lung health. So we do this in a couple of ways. One of the ways is really directly involving patients in research. And the other way is providing accessible information for patients as well and for the public. During COVID, we've done a lot of work trying to present information to the public in a way that is useful and accessible. So initially we did a Q&A where people were able to write in with their questions, and these were replied to on the website. So we would take the questions and make them slightly more generic, but then they were responded to by a respiratory professional, and then these were shared online. And this has been translated into 11 different languages. We've had well over 200,000 views now. And on the website in general, we've had over twice as much traffic as we did last year. So we've been really receiving a lot of people coming to the website for information. With the questions that we've received, we've actually had over 900, well, it was 900 when I wrote this presentation, it's probably over 1,000 by now, questions directly from the public that we've been responding to. So we've had a really good insight into how people have been feeling specifically with respiratory conditions regarding COVID, regarding their fears and the things they haven't kind of understood about what's been happening. What you'll see if you do watch the presentation online, I shared 2 videos in my presentation from ladies with respiratory conditions. So there was Isabel Saraiva, who is the chair of the European Lung Foundation, and she's a lady living in Portugal with COPD. I would really recommend looking at the presentation, even if just to listen to these two women and not me. It provides a really useful insight. So we've got Isabel, and then we also had Rita Barriuso. So she has sarcoidosis, and she's living in Spain. She lives in Madrid. And again, she provided her perspective of how it's been as being someone with sarcoidosis throughout the pandemic. And what both of them found, and both of the videos suggest, I summarised in one of the slides, was they both had a lot of concern over the cancelled appointments and the lack of access to healthcare. So this was whether routine appointments for COPD, sarcoidosis, or whatever condition patients may have had been cancelled, or people not understanding whether they should go to these routine appointments, whether it was safe to, whether it was better to stay away. And they both expressed their concerns over how that would affect theirs and other people's overall health if they're not attending these routine appointments. They did suggest some possible solutions. So Rita received calls from her general practitioner with reassurance and continuous updates about information of what the new processes were, and that reassurance that she should attend routine appointments. Both had issues with conflating their own symptoms, especially with COPD, with those of COVID-19. So not understanding whether a COPD flare-up was a COPD flare-up or perhaps actually COVID-19. And from the questions that we've been receiving into the inbox, we've had a lot of questions like this, where people are saying, I have insert condition here, I'm experiencing the symptoms of COVID-19, but these are very similar to what I normally experience. Should I go to the hospital? Should I stay at home? Should I treat it how I normally would? There's been a lot of confusion. And again, some of the solutions that Rita and Isabel suggested here was, again, just clear, easy to understand information. And again, the knowledge of pathways into healthcare. So just that reiteration of, they know that the processes have changed, but explaining how processes have changed and how patients can still access that care. And this has already been mentioned, and it sounds like the hospital in Barcelona has been doing a lot for this, but a lot of people had issues with distance from loved ones as well, and not knowing the amount of time that they would be separated from loved ones, whether that's people who have been in hospital because they have COVID, or people who are social distancing or self-isolating because of their pre-existing condition. And the answer to this, I'm not sure how feasible it would be if we had another pandemic, but clear guidelines about the length of time for lockdowns, especially, and the amount of time that people were expected to be isolating for. And again, that's something we got a lot of emails about. More clarity over who should isolate, and also structured and accessible access to mental health care. So often I think it can be overlooked that people's mental health will suffer, and people really have struggles with this. And I think that, well, not just myself, sorry, the patient, Rita specifically talks a lot about the absolute importance of structured, specialised, accessible mental health care. That's pretty much an overall summary of the presentation. Like I said, I would really recommend having a look online, just so you can actually hear what the women have to say, because they articulated it a lot better than me, and they both have really, really important experiences to share. I would also say, from a patient perspective, on the European Lung Foundation website, we have shared more experiences of patients throughout the pandemic, people who have had COVID, suspected COVID, and just the way people have felt with different respiratory conditions during the pandemic and their fears surrounding that. So I would definitely recommend looking at those as well.
Okay, Jessica, thank you very much. Very clear summary. And the final presentation is from the Dr. Antoni PLASENCIA, and we will move from the local perspective to the global perspective. Antoni, the floor is yours.
Thank you very much, Joan, and thank you to the organizers for allowing this opportunity to share a little bit our views. And our views is global, as you see from in my back is the Barcelona Institute for Global Health. So a little bit is an evolution of the previous vision and experience of Hospital Clínic and University of Barcelona around international, now more often called global health. We are basically a research and translation and education institution. And in that capacity, of course, part of our work has to do with dealing with international health organizations. And as I was asked, and you will see it in more detail in the video and in the slides that I won't show here, a little bit what I try to do is to review the response of selected international health organizations. So namely, institutions like WHO, which was quoted before by Joan, and from the European perspective, the European Commission, the European Center for Disease Control, and other main stakeholders that have a lot to do or a significant role in global health governance and the interaction with governments. So the idea was to review the response to the needs and challenges of education, especially during these first months of the COVID, and to identify some lessons learned and propose areas for improvement. And basically, what I like to share, first of all, it's important that different surveys in different countries, north, south, east, west, show that beyond scientists and health professionals, international health organizations are among the most trusted sources of information, both individually, but also collectively. And this is quite similar, as I was saying, in different organizations. So what comes out of these organizations, what is coming out of the organizations in response to the current crisis, COVID crisis, is generally well followed and not necessarily trusted, but at least well followed. And these different organizations have had different levels of response, both quantitatively and qualitatively. And just to summarize some of a little bit the overall appraisal. One is that communicating in a situation like this it has somehow different components. I won't go through that, but it has to do with risk communication. It has to do with management, communication around risk management. And of course, it has to do with communication at large in many other aspects. And so this is a challenge and at the same time a risky business in a context of complexity and of uncertainty, as was also mentioned by my colleagues previously. And these organizations, part of the challenge is also because they lack proximity to the populations. So basically, there's not a close interaction for obvious purposes, but at the same time, they have made formidable response efforts within a short period of time, both, as I was saying, in terms of quantity and quality. At the same time, some specific groups for different reasons, like patients or young populations, have not been targeted at least in the initial phases, and I will come back to that very briefly. And also in terms of the tools and the interactions, one of the things that we're seeing is that there's been limited communication strategies with other actors and with other platforms, despite the tremendous growth and penetration of social media. And that in part has also to do with the discrepancy between the needs and expectations regarding these communication roles of these institutions and the resources that they seem not to be getting, okay? So just in summary, to summarize some challenges, one is that something that you will see in the presentation is that there have been different efforts, maybe a differential effort, and that links with the quote from Dr. Tedros, the director of WHO that Joan was making earlier, is that these organizations are making a significant and differential effort compared to previous crises in the area of fighting misinformation, disinformation, and rumors. And definitely this is a differential approach. And if you go to these web pages, you'll see that it is a significant effort. In any case, as challenges and proposed actions, one is there still needs to strengthen the communication strategies, actions and resources in this context of uncertainty and confusion, especially regarding this trust and legitimacy of the many information sources available, and also the limited health literacy of large parts of the population, especially the most vulnerable population. We cannot take for granted that everybody is going to understand technical, scientific messages, and we need to tailor these messages, even more in the current situation, I would say. Special efforts to be upscaled, also regarding health systems from the patient experience, so this regards to this discussion today here, from public health, the experience of the citizens, so not only the patients, regarding the response from public health, adolescents and young adults, and the specifically complex age group and social group, as we see, to be able to bring their contribution to the COVID response, and also greater involvement in digital health tools, together with, I would say, partnering and accountability efforts. And just to finalize regarding the partnering issue, really what we see that all members of digital social networks, including, of course, these types of organizations, but also social media, healthcare providers, consumers, we all share the responsibility to help address the implications of the pandemic, and that there's already actions of partnering actions with social media giants like Facebook, Twitter, Instagram, that show that this public-private cooperation can be very effective in ways to somehow support credibility, support rationality, and be closer to people's expectations and to people's attitudes. And so in finalizing, I will just share with you these concluding remarks. Of course, communication is key because it's part of the preparedness measures, and global health, as we're seeing, that's why some of us are in global health institutes. The pandemic experience shows that diseases don't know about borders. Second, that international health organizations need to expand their communication capabilities deeper and wider to ensure adequate funding and to use more intensively novel models and tools of communication, and the greater need for effective cooperation between these organizations and other key stakeholders, especially with social media platforms and also emerging networks that are really innovative and that should be in the picture. So thank you very much for your attention. I'll be open for questions when
Thank you very much, Dr. Plasencia. At this moment, we will start with a discussion with the speakers. We can interrupt, we can change the questions, we can change the order. This is a serious debate, but it's not a formal debate with very strict rules. No? I think that the three speakers talked about information, and information probably is a key issue in the pandemic's management. And my first question is for Jessica Denning, and I want to ask, to what extent the information produced by the global organizations help the European Lung Foundation to translate or to produce the information, the specific information for the patients? Because one risk is the very interesting framework with a very interesting general information, but the challenge is to answer the questions of patients, in this case with respiratory disease. Is useful for you? What difficulties you have with this global information to do that?
Okay, so yeah, I think being a European organisation, of course, we have to produce information that is relevant to that really large audience, so it does lose some of the specificity than it would if you were targeting it at a very small group or a single country or city. I think sometimes that can be very difficult, and it does mean that the information across Europe that we've been seeing, and the information actually that we produce doesn't only go through Europe. We've seen a lot of a rise in the accessing of our information through South and Central America as well, especially our information in Spanish. And a lot of the countries that we provide information to don't necessarily have equal access to information. I think it's, yeah, I think that's the main difficulty, that we have, I would say, is finding that line, finding that balance between having something that's generic enough that it's applicable to a wide audience, but that it maintains a specificity that is actually useful, if that makes sense. And it's certainly problematic, and it's something that we've had to kind of address, especially during the pandemic. Yeah, I would say that's the main difficulty. If that answers the question, I'm not sure it does.
Thank you. If you have some comments spontaneously, you can interrupt and ask. No, but I have for you, for Dr. Plasencia, if you have the contrary, the citizens probably identify that each country, each region, different strategies to deal with the pandemics. No, to what extent are the global recommendations, the World Health, the international organization recommendations are applied by the local authorities? It's normal, this kind of variability, or just is an aesthetical or just formal variability, but at the end, the local authorities uses this? This is not just a discussion from the Spanish perspective.
No, of course, a global. Yeah, thank you. I would say that this whole subject of a global problem that is being dealt at the local level, and somehow the joint challenges that all populations and countries face, and then the response to the diversity and the oftentimes lack of coordination somehow puzzles the public and puzzles also different local authorities, for sure. What I can say, and I mentioned this earlier, is that these international health organizations are seen as somehow sources of trusted information, and therefore they are taking into account and look at these local authorities in many aspects, and I would say also individuals in the part that corresponds to them are sensitive to this knowledge, to the scientific knowledge and to the guidelines, as long as they are explained and presented in a way that can be understood. So this raises different challenges. One is the challenge of knowledge management in the face of a huge amount of, I don't recall exactly the number, the daily number of new papers, scientific papers, so that doesn't include other literature that comes out, that are coming out every day just on COVID. And so it's literally impossible to be able to get and synthesize and understand really the new questions. So there's a challenge of knowledge, scientific knowledge management, and there is also a challenge of independent advisory roles, which is, as we've seen in different countries, openly debated. And I think that never until now the debate between the role of advisory bodies and public decisions, either local, regional, national, or supranational, has been so much in discussion. So just to summarize, to make it brief right now.
So sometimes the citizens could we astonished with this different approach, or from the European perspective, the Sweden or Italy or Spain have different approach. But I think all the speakers emphasize the risk of the rumors or the bad informations. This is a question for Jessica and for Dr. Plasencia, for both. How at different levels, no? At the level of the patients, at the level of the organizations, how we deal with the rumors, with the bad informations, not just for some politicians that said extravagant things, but a lot of bad information, rumors. That is, how do you think that we need to deal with? Jessica, do you have specific strategies? This is really a big problem.
Yeah, it certainly has been, and it's certainly something that we have received direct questions from people who are really, really concerned with a particular situation that they've either seen on social media but it's not just social media. I think we can easily tar social media, but even in the press, a lot of the newspapers have been saying things that aren't necessarily true, and it's certainly caused a lot of fear. I think we need to battle it in a variety of ways, and I think first is increasing the trust in the large organizations. So people are accessing information from the World Health Organization and the ECDC and people like us. But it's about increasing the trust in those big bodies that people are accessing the information from, to know that they are the areas that they should be getting their sources from. And also providing more reliable information, and as Antoni has mentioned several times, about the accessibility of the information. So providing trusted evidence-based information that is in a lay language, that is easily accessible to people, whether it's in their own language or whether just the language that's used is very simple and very easy to understand. And also trying to teach the public as well to be critical of the things that they see online. And to not necessarily, well, online and in newspapers and on the news, and to really try and instill some level of critical evaluation in the things that people are reading. So I think there are a lot of ways that we need to address it from in order to be effective.
And then from the global organizations, there is some strategies to deal with rumors.
Yeah, as I mentioned, definitely the differential component of communication from this organization is in trying to deal with misinformation and disinformation, which means on purpose or accidentally, and then rumors. So there are these three components of a little bit the complexity of communication. As I was saying, really there are efforts being made, but both in terms of the tools and also the contents, to try to preserve something that is very complex, because science is an evolving scientific knowledge is permanently evolving. It's based on debate. It's based on precisely being able to respond to hypotheses and to demonstrate that previous truths are not anymore. And this is difficult to communicate to the citizen or to the patient. And so in regular times, this is already complex. So now it's even more complex because of the speed and the magnitude of the communication challenge. And I would only add that I think, of course, this is a collective learning process, but this is also a process to understand by these institutions that they need to work much more, not from a top-down approach in conjunction or in response to their governance role, but that their governance role needs to be disseminated, at least in this communication component, much more from a network perspective. And that includes bringing as somehow allies in these communication challenges, bringing somehow not the usual suspects, but the unusual suspects. And by the unusual suspects, I mean not only the experts, and just let me say that we have an epidemic also of experts. Some have called even of armchair experts, but also, of course, many true experts. But by the unusual experts or the unusual suspects is precisely people who are being followed, that are not necessarily experts, but are willing to make their contribution as influencers or as people that people follow, and that try to do this as best as possible, somehow as spreaders, as nodes to spread right information, adequate and useful information.
Yes, following this idea, Jessica, Antoni, do you think that the patient involvement in research could mitigate this or could translate the ideas? This is the patient and public involvement idea, or the open science, no? And perhaps in some cases, the scientific debate, it moves from the academia to the media. And these sometimes we will make mistakes because a negative study, for example, could be a good result in research, but in some cases a negative study, it's a bad issue. And the politicians participated in this debate, and then this is crazy because the different interest, it's sometimes conflicted. But the question is, your impression is that could be useful to involve more and more patients in the design of the research or in the evaluation of the research, or just to participate in the research for both?
Yes, so I 100% agree that would be beneficial from 2 points of view. Obviously, the more patients that we involve in research, the more understanding that patients and the public have of research and the processes behind that. But of course, involving them means that the research itself and the way especially the way it's disseminated, is appropriate and is understandable to the public, and hits the messages that they need to understand. So yeah, 100%.
Yeah, I agree. And just to complement what Jessica was saying is that I think, and in the presentation, I make a very short reference, which is accountability. I think somehow evaluation that brings in patients and citizens in perspective can be very helpful for accountability purposes. And this as part of a learning process for collective improvement. So definitely both patients and citizens at large are part from a research standpoint, but also a research for improvement, for in this case communication improvement, in to better response to crises like the ones we are now facing.
Yes, I commented the participation and involvement of the patients because during the lockdown we asked our patients what kind of information they need. In order to the chronic patients, not COVID patients, no? Because as Dr. CASTELLS said before, we try to ask patients about the impact of lockdown from the chronic disease. And we want to show the patients that we are interested in the chronic disease in spite of the big problem in the hospital. And curiously, the patient said we need more practical information, no? For example, how to attend the hospital if we have a blood analysis, how is the condition of the patient clinic if I receive an appointment to visit the hospital. And perhaps in some cases asking patients, probably we discuss about the vaccine or about the drugs, and we forget daily life information that is very useful for the patient. This is the comment I said before about the patient involvement, because probably we will not change, but we will improve the strategies of the communication. In your previous intervention, Tony Plasencia, you talked about quickly about the experts, the concept of the experts, no? And sometimes talking with patients, especially journalists, ask local experts, the so-called local experts. In part, it's logical because it's difficult for an international organization to answer local questions, and we need to. But do you think that the definition of the expert is misleading in some cases? Because, for example, the chief of the service of infectious disease is a top level, for example, research. I'm not sure if he can answer questions about the return to the school or the risk to return to the school, because it's a very complex question. No? And what's your opinion? How we can deal with the needs of the citizens about the expert opinions? This is a need and it's logical. Experts should be local in order to understand. Local, I mean not the city, but the country, the region, the area. How
Yeah, the good news, if I can answer, the good news is that maybe never before science has been so much at the forefront of people's discussions, people's expectations. So that I would say this is good. Basically, because what we're saying is that science is the collective effort to know the truth, and we need to understand the truth to be able to face the challenges that the situation means. At the same time, the difficult part of this is the complexity, dealing with complexity and uncertainty. And from the point of view of the patient, the point of view of the citizen, try to understand a little bit, try to identify what is true and what is not so true. And so definitely I think that we need, and maybe also patient organizations, I'm sure some of you are doing this, is to try to provide a little bit a toolkit somehow on what sources, what trusted sources to use, to check, and what maybe are other sources that deserve other considerations. At the same time, from a scientific standpoint, let me say that we are facing another challenge, which is scientists tweeting all day, and in many cases with difficulties to make the difference for the readers of the tweets of what is evidence and what is opinion. But they are trusted sources. So again, this is a challenge that happens, which is what is scientific evidence and what is opinion, sometimes opinion on others' evidence. So again, I don't have a clear response for that, except that maybe we should all make an effort to strengthen the trusted sources, to strengthen the networks of trusted sources, and to help bring this information closer to patients and to citizens.
Thank you. And also we have two extra factors, no? That it's ego and politicians, no? Yeah. That makes a complex mixture, I suppose, no? To deal with this. Okay. I want to move to an aspect more close to the patient perspective. In the hospital, we are very sensitive to the non-COVID patients with chronic conditions. Jessica, in your opinion, or from the European Lung Foundation, you think that the patients have some impression of a stigma, or some impression that are the second level of the care, or the patient understand the complexity of the situation?
Sorry, could you elaborate on that? So you say impression of stigma regarding COVID, or regarding their own?
No, regarding the chronic condition.
Or
no, regarding the chronic condition of the patient, not the COVID. No.
I think there are certainly issues. I think, well, obviously it will be very variable for whatever conditions the different patients have. But one thing that to relate stigma and COVID, and something that's come up an awful lot, has been patients at the moment with respiratory conditions and fears over how their pre-existing condition could now be perceived because of COVID. So for example, people with chronic cough or asthma or COPD or any condition, well, a lot of respiratory conditions with cough as a side effect, are now facing large amounts of stigma due to COVID, and just trying to live their daily lives, but not being able to cough in public. And certainly people with chronic cough have been coming to us with, not wanting to leave the house particularly. I would say on a positive flip side to stigma, and COVID would be people with who are awaiting lung transplant or who have had lung transplant. I was speaking with a lady just yesterday who said that since the adoption of face coverings and masks due to COVID, actually the stigma that she feels leaving the house now as someone who is on the transplant list has actually gone down, because she was always wearing a mask, well, face covering, and now everyone is. So I think COVID has certainly had positive and negative aspects on patients' experiences of stigmatization of their pre-existing conditions.
In your video, this is very clear, the point of view of the Isabel Saraiva and Rita Barriuso. The patient explains very well, Isabel explains very well the fear for life-threatening disease, for disease symptoms, as you said before, not difficult to separate with COVID, or Rita Barriuso reflects very well the fear of the difficulties to access to the specialized services because they are very busy caring for COVID patients. From your perspective, you can help us to identify some priorities from the perspective of the patients, some priorities in order to improve the experience of these patients, taking into account the difficulties of the context.
Yeah, of course. So I actually jotted a few of these down from the videos and from other patients that I've spoken to. So I'll read their words. So I think, first of all, it's very clear from the videos, the understanding of how to access regular services and what to do in an emergency. So if someone is having an exacerbation, whether the processes would be different and how they can access their healthcare. They want to know what the processes are and how they've changed, and how to access healthcare safely as well. Secondly, again, this ties in, but the missing of routine appointments, assuring that these are still in place where possible, and allowing people to understand how they can still safely attend their regular appointment. Timelines and specific disease information. So again, I've touched on this at the very beginning, but it's something that the lady spoke about quite a lot, was the fear of the amount of time that they were going to be in isolation, or the fear of the amount of time that it was going to take for routine appointments to start again. So this is obviously, it's hindsight rather than something that's occurring now. But if there is a second wave, being very, very clear about timelines and how long people are going to have to stay at home. We've had a lot of questions as well about staying physically active. So a lot of respiratory conditions do rely on staying physically active to maintain their health with their condition. And when people were locked down, and there's still a lot of people obviously that are still in isolation, so effective information about how to stay physically active while stuck in the house or while only able to go out for small amounts of time. As Rita mentioned, structured and specialised mental health support for patients and carers, and family members as well. I think they're often overlooked. So that's something that came out from our patients. And also something that I'm sure we've all experienced is technical support for remote appointments. So a lot of hospital and doctor's appointments have gone online or over the telephone. And while a lot of us are very comfortable with technology and we have access to that, a lot of patients won't have access to technology or may not have an understanding of that. So also looking into what support is being given to people from a technological standpoint, and the appropriateness of some of the remote appointments as well.
Thank you.
Yeah.
We are on time. I have the last question for Antoni Plasencia. And in your last slide, you talk about the cooperation and the need of the cooperation. I understand with countries, the organizations, etc. But my question is how patient organizations or hospitals, that mean the frontline people or the people not involved in a big organization, how we can contribute to this cooperation? What's our role in the cooperation? That I agree absolutely with you.
Sorry, you mean the patients and the citizens, or you mean hospitals and healthcare
I meant the
centers?
patients' organizations or hospitals. That means people in the front line with a specific interest in the disease, and that we will share with you the idea of the cooperation.
Yeah.
But sometimes is that I cooperated with money, with activities, with attitude. This is a...
Thank you for the question. I think that brings to one of the challenges that I mentioned that these organizations have is that they are very far away. They are very distant from the citizens or from the patients. So I think part of the role that the hospitals, healthcare centers have is precisely to be some sort of an intermediary organization between some of the messages and some of the contributions of these organizations, and try to retailer and to adapt that to their patients, to their users, because they are much closer and probably more trusted also, because somehow closeness is often linked with trust and with confidence. So I think there's a role, and just let me incorporate two things here. That needs innovation, and again we are dealing with sometimes with a 21st formidable phenomenon, sometimes with 20th century tools in terms of communication. So we need to be innovative in that sense. And of course, healthcare organizations not always have the tools or the priorities to do that, but just note this, I think this to be kept in mind. And the second thing, which I want to mention, although it's not specifically related or only related to your question, is that one of the challenges of this pandemic has to do with equity. We are still not able to measure, or we are only seeing somehow the tip of the iceberg of the tremendous impact and contribution of inequalities, social inequalities, which means also, again, health literacy inequalities in the response and in the impact on the population. So definitely all organizations, both the local, both the close and the far away, both the local and the regional and the international, need to be very active together with scientists, because we need, of course, the evidence on what now is more of an intuition and some scarce preliminary data, but that definitely one of the impact, this impact is differential. This health impact is differential, and it's going to be, it's already being much tougher for some sectors of the society in many places of the world, I would say in all places of the world. So communication and interaction needs to keep in mind this dimension of the crisis.
Okay, we have a question. I don't know if from the audience, but here in the Zoom, I'm not an expert. We have a question. If the crisis began again, what more could you do to reduce the patient isolation as much as possible? This is the question. I don't know for what, for both. No, for Jessica Denick, you have any idea how to reduce the isolation of the patients? And then I want to ask Tony Plasencia, we can expect some changes in the duration of the periods of isolation, 14 days, 10 days, in order to answer this question of the audience. Jessica, do you have any idea how to reduce the impact of isolation of the patients?
So one thing that we found has been very beneficial is throughout the pandemic, so we work with a lot of patient organization groups, and they have been key to reducing patient isolation throughout the pandemic. So I think a very good example is, oh, the name of it's going to evade me now, but there's a patient organization for lung transplantation in Italy. And they've made a really strong connection with all of their members throughout, and they've put a special focus on teaching all members how to use platforms like Zoom or Teams or Skype, whichever you choose to use, and rolling that technology out to all of their members, and having really routine meetings. So once a week, once a fortnight, patients have been meeting to discuss just anything. So obviously they've had their condition as something that's brought them together, but they've actually become real support groups for people who have concerns over COVID. And it's not just that group. I've heard from a lot of patient organizations all over Europe that's been a really effective strategy. So I would say really promoting these support networks that patients can be involved with, that put them in contact with people with the same conditions as they have and are experiencing similar considerations that they are, has been a really effective way of reducing isolation for a lot of people.
Thank you. And Tony Plasencia, from your point of view, that you consider that the increase of knowledge could change the strict rules of isolation, not just for the grandfathers, but we learn a lot of things in a short period of time, and we increase knowledge every day, and that could change something or not?
Yeah, absolutely. I think basically we're already seeing what were very strict lockdowns, what was called the hammer strategy by some, to now the dance, which is a little bit more diversified ways of restricting mobility and ensuring protection, distance, and so on. And this is based on knowledge also. So definitely, I think there needs to be a very close interaction between the relevant questions, the ability to respond scientifically to those questions. so to get relevant evidence and to be able to introduce, to implement as quickly as possible in the decisions and in the implementation of those decisions. Always with the perspective that nothing is black or white, and that this is a very, how do you say it, a very unstable relationship between risks and benefits. And so definitely what this means is that we have to see this as a learning process, and that requires independent assessments and accountability, and that requires the update of the decisions, and of course the contribution, or the close interaction between this triad of course, governments and authorities, scientists and healthcare providers in this case, but also other providers, social care providers and others. And finally, or last but not least, patients and citizens at large. And I think that somehow this is what happens every day, and hopefully science may help in providing somehow better outcomes and positive management of the crisis.
Okay, thank you. We don't have no more questions from the audience. If we have some feedback, I will share with you the ideas that we collect this. And on behalf of the Shared Patient Expression Associations, I want to thank you for your time and for your knowledge and for your kindness to participate in this meeting. Jessica and Antoni, thank you very much. We use English as a common language, but I want to say goodbye, not just in English, because we have the audience, it comes from different countries. Thank you very much, the audience, to participate here. Muchas gracias a la audiencia por participar en esta sessió i moltes gràcies per la vostra atenció, especialment al Chito i als tècnics que ens heu ajudat, al Beto i tota la gent d'aquí que ens heu ajudat. Benedak pour Julian de Hop-Gisein-Bernstein, et merci beaucoup pour votre attendance, votre participation dans cette symposium. Jusqu'à la prochaine. Thank you very much. Bye bye.
Thank you.
Muchísimas gracias.
Gracias. Gracias, Joan.
Adeu.